Excellent. I'll let the chief sit down a bit. We finally got connection. We're very pleased to have the opportunity to address the group today. We all understand that the pandemic certainly had some far-reaching impact on our organization, on our providers, both personally and professionally. So in this context, Chief Warrant Officer Gauthier and I want to thank everybody for your professionalism and your patience throughout this crisis. And certainly your ability to adapt has been quite remarkable. The initiative that you have to do webinar like this in that period of chaos is great initiative. So you get ready for the next phase, the return to work, and to have our clinics ready and up and running. So the intent of this webinar will be to provide all dental personnel working in our facilities the ability to review with partially Major Fournier, which developed with the task force this directive, and understand the mitigation measures that needs to be taken place in our clinics before returning to work in a more normal fashion, and as well as give you an opportunity to ask questions. So hopefully we'll achieve that goal today. And before we carry on, I'll ask Chief Gauthier to say a few words. Please, Chief.
Thank you, sir. Good morning, everybody. First off, I just foremost want to thank the task force, Major Fournier, your entire team, and the CDO for all of your research, work, sweat, and tears, and sacrifice, I'll say, that went into the development of this directive. It's a lot of information, and understandably, there will be a learning curve for a period of time to absorb all that's here for the implementation. So just like with any challenge, communication will be key. If there's something that you do not understand, or perhaps there's something that the directive doesn't speak to, then I encourage you to use your voice and voice your concerns and your questions. So basically, if we work together, we will be successful in protecting ourselves, our co-workers, and of course our patients. Thank you, sir.
Thank you, Tracy. So this webinar will principally look at the directive per se and go into technical details as well towards the end of the presentation. And Max will lead that aspect. But as well as to give you some background information on how we got to this point and what we see of it in the future and a few weeks to come as well. So Max, let's go to the next slide, please. So I apologize, from where I stand, the slide is very, very small. I can't read it, so I'll put it up my computer here so I can see that slide. So this slide depicts the chronology of what happened since January. So you can see that from the onset in January, we sent a communique on triage and signage. And then there's been a series of communication that's been provided and guidance and directive that were provided with increasingly prescriptive and more details. And that's all in response on the evolving situation with the COVID crisis. Now we arrive at a point, now we had a third variation of the directive, and we're going to look at how it's going to evolve in the next few weeks as far as the PPE is concerned. And I know a lot of you have a lot of questions about PPE probably, and some of the disparity there may be with some of the colleges. And we'll get to this and discuss that a little bit more in details. But this timeline that you see there has been 3 series of formal communique about the type of care and how we provide care in our clinics. And it's been since the pandemic declaration 11 March by the World Health Organization. We have curtailed the type of treatment that is provided and provided various level of directions and guidance. We have as well the frequently asked questions that was provided at some point during the pandemic, and the task force is reviewing these frequently asked questions. So that's certainly going to help as well to interpret and answer many of the questions that you may have about the current directive. So Max, if we could go to the next slide, please. Slide number 4. So the COVID-19 crisis, as you all seen, has been evolving rapidly, especially when it comes to the scientific, clinical, and regulatory aspect. There's a load of information out there. So in order for the RCDC to stay ahead of the crisis, ahead of the curve, I stood up the RCDC COVID-19 task force back the 24th of March. Each of these individuals have been selected to be in the task force, have been picked for their talent and expertise, and I rely heavily upon their guidance and recommendation to make decision of where the CAF oral health care system is going. You can appreciate that given the dynamic nature of the crisis, there's been a lot of material that they had to cover, a lot of ground that they had to cover. And the team members worked extremely hard in order to meet the growing demands. Some of the challenges, as you can see on the slide, have been a significant issue for the task force to stay on top of the game. As various regulators have their own timelines. They want interpretation of the public health officer direction and directives. They're not working all in synchronicity. So all this has been a challenge, as well as the public health measures have been different from one province to another. And we see that particularly acutely right now. So that's been a challenge again for the task force to stay on top of all this information, and the reason why it took so much effort for them to achieve that. So if we go to the next slide, please. So the task force being stood up, and Major Maxime Fournier is the task force lead, and he reports directly to me and coordinate the ongoing work from the task force and other support that you have with the task force. You have to understand that we have Major Fournier, Major Dusty, Dr. Gary, Dr. Hart, Major Aldrin, Major Messier, Warren Plant, and Captain Vaux have been part of that team. These individuals, again, work extremely hard, and I thank them for the tremendous effort to bring us where we are now and to guide us as well where we're going to go next. So some of the activities that the task force has been doing. So if you have the next slide, Max, please. So you see these are the core elements that the task force has been working on. Lots of material, lots of reading that you probably went through over the past few weeks. You can appreciate with the bibliography that they had to do quite a bit of research. We're very fortunate in the health services to have not only our task force, but we have Force Health Protection. That's been quite an enabler in developing our directives. We're also involved with the regulators. I'm sitting at a table with the regulators every week to discuss their guidelines, our guidelines, do some comparative and share best practices. We involve as well with the CDA. There is an infection prevention enhancement working group with the CDA that informs the associations as well as the regulators on where we should be going as a profession. So we have all involved at the national level as well, and that informs the development of our directives. So the clinical directive now take into account the current knowledge about the disease. It has been developed principally to protect our personnel, our patients, and ergo the community at large. We don't want to be a vector of transmission of COVID. So the directives and the various iterations of the directives have been taking that very seriously and take that as an objective for the our people, our patient, and our community. Major Fournier will review more in details in the subsequent slide, the symptomology as well as the mode of transmission of COVID-19. So we all have a common understanding of this, and the directive provide this background information as well. So I just want to give you as well a bit of situational awareness related to the directive. It's the third edition, as I said earlier, the other one being on the 26th of March and 7th of April. It outlines several measures which will effectively reduce the risk to our providers. It looked at the emerging scientific evidence and guidelines, as I said earlier, from the regulators and the Public Health Agency of Canada. We look at CDC as well, and a myriad of other information to develop these directives. In this latest version, we have introduced as well engineering controls in order to reduce risk to our providers and our patients. We have moved from a standard universal precaution use of PPE and approach to care to a transmission-based approach to care. And when I talk about the engineering control, there's the administrative control as well, as we have introduced in our clinics. And the directive guides you through this. And Major Fournier will review the hierarchy of control from the National Institute of Occupational Safety and Health, the NIOSH. So you're going to see that the reason why we targeted at that certain level to increase protection for all people. Given the situation between Canadian provinces and potential future outbreak, it may be required at some point to dial back access to care and be more restrictive, depending on the nature of the population in certain province, in certain area, or even across the country if there was a second wave. So the design of the directive allow for dialing up and dialing down access to care. And you will be guided as time go by in that regard. This is going to be an interesting time for everybody. It's been an interesting time, so I beg for your patience, your ongoing patience, as we go through the ongoing pandemic. You're going to have, again, lots of questions of what's happening with other agencies, other regulators. You're going to compare notes, but rest assured that our team is working extremely hard, and we've been a beacon and an example to follow by many of the regulators. We provided our directive, we provided our report on the air filtration unit that we'll get back to in a few minutes. And you may notice that with certain regulators, they will allude to air filtration units as part and parcel of treating patients that are at higher risk of COVID. So that's all been generated from discussion that we had with the regulators and the document that we shared with them as well. So on that note, I will let Major Fournier now go a little bit deeper in the more technical aspect of the directive, and I'll stay back with the chief and will be there as well for answering some of your questions. And if we don't have the answers for all the questions, we'll certainly get the answers for you in due time. So we'll take notes and get back to you. I'm going to have a bit of inject at some points during the presentation as well to give you further background information. Major Fournier, please.
Thank you, sir. Good morning, everyone. My name is Major Fournier. So first, I'll talk a bit more in detail about the different aspects of the new clinical directive that came out 10 days ago, 7 days ago for the French version. So hopefully everyone's had a chance to read through it and go through the details, and hopefully we can have some good questions at the end. I'll also talk about the air filtration units in more technical terms at the end of the presentation, because I'm sure a lot of you are kind of wondering why we have those AFUs in the clinics and what they do actually for us. So I'll talk about that. So the directive itself is a little bit different from the previous versions. So the main document itself is kind of intended as to form the backbone of the directive. So it presents the key concepts as well as the definitions of the directive itself. The content in the main document itself is less likely to change over time because it's actually that it's concepts and definitions. Where the key information is presented is in the annexes. Those contain a lot of information. There's a lot of them, a lot of annexes, but that's where most of the meat of the directive is contained. This information is actually more likely to change over time, but it can be easily updated, and we can republish those annexes individually. For example, if our PPE stance changes over time, we can easily change that and republish that annex. Most of the annexes are also single-page documents that are easily printed out and can be used at the point of care. So that should facilitate the tasks of everyone. So the directive itself is broken down into 3 sections. So there's section 1 is the introduction situation. The CDO already mentioned those points, and I'll talk about these 2 in particular later on in the presentation as we go through the annexes. So I'll just skip that slide. Section 2 contains a lot of information. It's more general information regarding COVID, PPE, that type of stuff, but it should be read in detail because it contains a lot of valuable information for people who work in our clinics, both administrative staff and clinicians as well. So these are the topics. I'll go into detail about each one. So in regards to COVID-19, so we present some information about its symptoms and transmission. So being in Canada, we have to follow the symptoms that are provided by PHAC, the Public Health Agency of Canada. And these are the 5 symptoms that they list. So fever, cough, sore throat, runny nose, and headache. I'm sure everyone's heard that in the US, for example, one of the symptoms that's listed by the CDC is loss of taste, loss of smell. But in Canada, it's not one of those symptoms. So that's why it doesn't figure in our directive. So the symptoms is pretty straightforward. Transmission is a bit more controversial. What PHAC states is what's listed here on the screen as of today. So what most people agree on is that COVID-19 is spread through respiratory droplets. That's pretty much a slam dunk. What's a bit more controversial is the other modes of transmission that are listed in the directive, so namely the fomites and the aerosol transmission. So you can see that the PHAC definition there, the 3rd point is talks about the fomites, but it does not list airborne or aerosol transmission. So there's a lot of speculation out there, a lot of research that's being done. And this article came out of China in early March. So that seems like years ago now, but a few months ago, this is something that was theorized based on their experience in China in dental settings. So this is specific to dental clinics. And this is, in theory, how COVID-19 could potentially spread through a dental clinic. So you'll notice, I don't know if you can see my cursor, but in the middle, close proximity. So that pretty much talks about the respiratory droplets that everyone seems to agree that is a mode of transmission. And as you can see, droplets compared to aerosols, the difference is basically size. So they're both fluid droplets, but fluid droplets are larger than 5 microns typically, and aerosol droplets are smaller than 5 microns. And droplets can be transmitted from one person to another through direct contact. So somebody coughing or sneezing or even talking can produce fluid droplets, which land on another person's mucosa, so in their mouth or in their eyes. So that's called droplet transmission. Fomite transmission is at the bottom here, so where the droplets actually land on inanimate objects and someone else then touches that surface and then touches their face. So that's the basis for those 2 modes of transmission. And you'll notice that they both rely on fluid droplets. Aerosol droplets are a bit more controversial. There's no real consensus out there in the scientific literature, but in theory, fluid droplets, because they're so small, aerosol droplets, because they're so small and so light, they can stay up in the air for longer periods and travel further through the air. And they can be inhaled by a person and then cause disease. So that's the theory of it. But as you can see, PHAC does not list that as a mode of transmission. So aerosols and COVID-19. So the WHO actually just published on Friday last week something that recognizes that there's a huge lack of research regarding aerosols and COVID-19. So they state that, I'll just move that out of the way because I can't see. According to the current evidence, COVID-19 is primarily transmitted between people via respiratory droplets and contact routes. So that's what we established on the previous slide. But they recognize that in certain circumstances and settings where aerosols are generated, it may be possible that COVID-19 could be transmitted through the airborne transmission or aerosol transmission. But the last sentence pretty much says it all. So it says that high quality research, including randomized trials in multiple settings, are required to address many of the acknowledged research gaps related to aerosol generating procedures and airborne transmission of the virus. So there's a lot that's unknown about this disease. And I think that kind of reflects our posture because we know so little, and also because there's no effective treatment and there's no vaccine yet for this disease. And at the bottom of the screen, so that's the CDC's stance as of just over a month ago. So again, they recognize that we are still learning about how it spreads. So aerosol transmission is not, there's no consensus out there.
Hey, Max.
Yes.
Listen, I just want to say that, yes, we can see your cursor, and we actually have a question regarding PHAC. So what does it stand for, and why is it important for us?
So they are they're the Public Health Agency of Canada. So they're the federal health agency separate from Health Canada that's responsible for overseeing the health of the Canadian population. In a sense, they're kind of equivalent to the US CDC. And some people confuse sometimes the Health Canada and the PHAC. So Health Canada is more of a regulator in terms of medical equipment, medical research, that type of thing. And PHAC is actually responsible for the implementation of public health measures.
Great, thank you very much.
All right, so this figure here, this chart will look familiar to anyone who's seen the directive. So this is not from us, so it's from the US CDC, or actually NIOSH, which it's a way to mitigate risks associated with hazards in the workplace. So it's not specific to healthcare or viruses or anything COVID related. This is way before COVID, but you can imagine it can be applied to a construction site, for example, where there's a lot of hazards to the workers, and how the employer can reduce the risk of the hazard to the employees. So on the construction side, if there's a hazard, it can be removed, it can be eliminated. So that's kind of the overarching principle, is that you have to work your way from the most effective, which is the blue, to the least effective, which is the red. And not to say that PPE is not effective, it should be seen as kind of the last barrier, the last resort before you're exposed to the hazard. There's things that you can do ahead of that, before it gets to the PPE, to reduce the risk to the employee. So if we talk about COVID-19, we can't really eliminate it very easily. It's here, it's in the population, so we have to deal with it in other ways. We also can't substitute it. So for viruses or pathogens in general, what we apply is typically the last three. So engineering controls, administrative controls, and PPE. Engineering controls are, for us, we have the enclosed operatories, we have the air filtration units, and as a lot of clinics have already had installed, the plexiglass shields. And administrative controls are changing the way we work. So they're our directives, our public health measures like physical distancing and continuous masking in our clinics, triaging patients before they show up to reduce the risk, assessing the risk associated with treatment, limiting the production of aerosols. Those types of things all reduce our risk of exposure before the patient actually, shows up in front of us. And lastly, we have PPE. So we have different PPE postures based on the level of risk associated. So different, levels of treatment. We have PPE for administrative staff and for patients as well. So we have different levels. So I'm just gonna give it back to the CDO here for a few slides. He's gonna talk about the reason why we have those air filtration units and give a brief about the current situation. Sir?
Okay, so he should be unmuted. I just muted him because there's a little bit of background noise. Sir, you out there? Just give him a second. While we're just kind of waiting for a pause here, my dear friend Major Mahmood has the same question he's been asking me about. So his question is, would there be consideration of lowering risk level? And I know that you might not have gotten to this point in the presentation, but I'm just going to ask it at this point because we're just on a pause. Would there be consideration of lowering risk level from high to low for endodontic procedures performed under a well-sealed rubber dam after a hydrogen peroxide swab? This is assuming that the air produced would consist solely of tooth material and pulpal tissue.
Yeah, so that's a really good point. So there's ways, and we'll get to that in a few slides, but yes, it's an evolving situation, and our posture is not static. It's gonna change over time, and there's a reason why it's called the Interim Directive. It's based on the current evidence, and as the evidence changes, and our postures will change as well.
That's great. Thank you very much. I hope that fulfills my friend Major Mahmood. Sir,
so maybe you can hear me now?
Yes, sir.
Excellent. Perfect. So let's carry on. Good answer, Max. And it was an excellent question as far as the level of PPE. That's something that we'll continuously monitor, and it will evolve. It will evolve based on the level of risk, based on the appropriateness of the PPE, and certainly already after 1 week, we're looking at the level of PPE for various procedures, particularly when it comes to low-risk patients and low-risk procedures, and the level of PPE to be commensurate to the level of risk. And you have identified something that in our directive shows that wearing high risk in the production of aerosol, even in a low-risk situation, we wear high-risk PPE. So that's being revisited particularly intensely in the past couple of days. So more to follow on that, and expect an update again on the directive, particularly on that annex. So coming back now to the air filtration unit, we discussed about the hierarchy of control, and we all understand that PPE is the least effective of all measures to reduce exposure to our providers. So that's why from early on, knowing this great concept, we look at introducing engineering control. And if you look now at the slide that you have in front of you about the air filtration unit, PIAC, their infection prevention and control for COVID-19, this is the second interim guidance, but the first interim guidance had the same concept. We wanted to give you the up-to-date, but when we made a decision to go in that direction, we had very little information, but still PIAC and CDC were discussing about engineering control. So when it came to the guidance for acute healthcare setting, PIAC was saying that individual that may be at risk of having COVID or having COVID should be treated in a airborne infection isolation room. That is typically a room that has a negative pressure. And it typically is a room that's enclosed. You need to have an enclosed room. So if you could not have a negative pressure, you needed to have an enclosed room, as well as the required PPE, the N95, the glove, gown, face shield, and eye protection, or eye protection. So that's where the idea sparked, because we're looking at the various clinics at the beginning of the crisis. If you remember, there was, I believe, 5 clinics in the entire province of Quebec that could see patients with COVID or potentially having COVID. In Nova Scotia, there was 3 clinics. But we need to be able to provide care to our CAF member. We need to keep them operationally fit and address their emerging issues with dental emergency or urgent care or emergent care. So this is where the idea started to germinate. So if we look at the next slide now, again, understanding the concept. So CDC introduced the concept of air handling as an engineering control, introduced the concept of HEPA filter. This is a more recent version of what we originally had with the CDC, but we understood this was the path we needed to go in order to be able to expand care to our CAF member. So this is really where the idea started. So we acquired the team at the Directive, BDS4, look at various components on the market where we could bring in and do tests with. So we acquired 1 kit and did some tests from there. So the ADM mat has been a great partner as well, because one of the other issues that we found is in our NDC, the integral HVAC was high velocity HVAC with no filter at all. So you understand that the turbulence and the amount of air going through the system without having any filtration was an issue to us. So ADM Matt looked at this and developed a filter, a significant filter that we put on our HVAC now. It's 24 inches by 24 inches by 12-inch thick. So that gives you an appreciation of how seriously ADM Matt took that. So they developed that concept. And now we have that in 6 of our NDC, or we'll have that in 6 of our NDCs. The retrofit is ongoing. As well as we had a decision brief, because I wanted to present that to the Commander Health Services Group and get the thumbs up so we can expend money and buy some of these kits. And we got a thumbs up to acquire up to 31 AFUs, air filtration unit combo, in our clinic, which we've done. And it's ongoing. We started with 18 plus 3, and now we crank up the order to 31. So that's going to be found in many of our clinics. And we completed the initial tests, and we requested to have more tests with another agency. And this is where the partnership was so important. We worked with Force Health Protection in the health services, and then did the validation of these tests by another entity called the Quality Engineering Test Establishment from ADM Math as well, outside our agency, giving validity to what we've done and showing proof of concept that this is actually work to reduce risk. So our current situation right now, well, it's been operational in many of our debts, as you can see on the slide. More will be shipped in June, and the next shipment will be confirmed by the manufacturer when it is available, and you see the other debts that will receive these devices. So that's why now you have in the interim directive a significant portion of that directive that address the utilization of the air filtration units. Again, this is all to reduce the risk to our providers. And this is to, as well, being able to treat patients that are potentially COVID-19 infected. So I think now we're going to go back with Max. It's going to go in greater detail about the air change an hour and things of that nature, and more in detail as well in the utilization of the air filtration unit. Max, please.
Thank you, sir. So as per the directive, so engineering controls are a big part of that. So there's 2 main components to it. So there's the enclosed operatories, where we can actually measure the air changes per hour. And there's also the air filtration units that I'll talk about a little bit later. So the air changes per hour. So I'm sure you've heard about it from the different provincial regulatory authorities. Everyone's talking about it now. It's the hot topic of this month. But we've introduced it into our directive with this table that you see here, table 2. So these values come from the US CDC, again pre-COVID-19, and they mention, or they are theoretical values on how long it takes to clear the air of pathogens or of particulate matter that's floating around in the air, based on the number of air changes per hour. So if you have, for example, 2 air changes per hour, that means that every 30 minutes there's a complete turnover of the air within the enclosed room, and it will take a long time for the pathogens to be removed from the room. It's also not a linear situation, and I'll explain why in a few slides. So you can see, to get 99% efficiency, it takes 138 minutes, but it takes so much longer to get that extra 0.9% to get 99.9% efficiency. And of course, if you increase the number of air changes per hour in your room, you'll increase the turnover of the air, and it will take less time for to get efficient removal of the particulate matter. The picture on the right here shows our experimental setup that we did with Queedy. So if you've never seen the AFUs, there's more pictures later, but this is the chair side AFU on the right. So that's the unit itself, and there's a cone, the tube and the cone that is in the operating field. And the one in the back at the patient's feet, that's the ambient AFU. So a little bit of technical details here. So there's a difference when you have particles that are floating in the air. There's a difference if you have stagnant air or turbulent air. So stagnant means there's absolutely zero air exchange. There's no one in the room. There's no movement of anything. There's no airflow. If there's people in the room, they'll move around. They'll stir everything up, and they'll also breathe. So they'll create air movement. But if the air is stagnant, the particles will just slowly fall down to the ground in a linear fashion. So the larger particles, which are heavier, will fall faster. The smaller particles will be lighter and will stay up in the air longer. But that's not really representative of anything that's going on. So most cases we have turbulent air. So there's people walking around, there's movement, there's air exchange. So that's a bit more realistic. But you can see that if people are moving around, it kind of stirs everything up, and the particles can stay up in the air longer. So it will take longer for them to hit a surface. And this graph here kind of shows why it takes so much longer to get to 99.9%. So if you say that this point here is 50%, it takes a lot longer to get to 99, and then 99.9 will be even longer. Also, particle size will affect it, as I mentioned. So the larger the particle, like fluid droplets, if we cough or sneeze, most of what we produce is fluid droplets that are larger, and they'll settle on surfaces much faster. So you can see 100 microns here will settle in theory in about 5.8 seconds, or sorry, that's the half-life of particles. So at 5.8 seconds, half of the particles will have settled. And then the smaller you go, you can see it takes so much longer for them to settle on surfaces as they get smaller. And the reason is they're lighter, so they'll stay up in the air. They're more likely to be kicked up by turbulent air. The next subheadings of section 2 are hand hygiene and PPE, and I'll just skip those because I'll talk about them in more detail in the annexes. And the next subheading is aerosols. So famous aerosols in dentistry. So I listened to the CEO's briefing on Tuesday, I think it was Tuesday. As he mentioned, so aerosols are not new to dentistry. We've always created aerosols. It's not because of COVID that we suddenly have aerosols in our dental clinics. It's also not new to medicine. It's not a new concept. So we've always created them. And you can see here the picture on the right. This is kind of what we're talking about. So this is an ultrasonic scaler, and then you can see the mist of fluid droplets or aerosols that's created there. Size-wise, you can kind of see fluid droplets as a continuum. Most researchers delineate aerosols as less than 5 microns and fluid droplets as bigger than 5 microns. In dental clinics, the quantities that we produce will vary by the instrument that we're using. So again, think of it as a continuum. So in dentistry, most of the greatest creation or production of aerosols is generally thought to be from the ultrasonic scaler, just because there's by its very nature, it creates a lot of a fine mist of water droplets. And then, for example, high-speed handpieces might be a little bit less. Slow-speed handpieces can also create aerosols. So we do mention that in the directive. It's just the way we chose in the RCDC to delineate between non-aerosol and aerosol generating procedures was to put the slow-speed handpiece as in the non-aerosol. But they can also create small quantities of aerosol, but it's much less than high-speed handpieces. It also depends on the treatment type. So if you're, scaling teeth with an ultrasonic scaler without, obviously a rubber dam versus a high-speed handpiece treatment with a rubber dam, there's a huge difference in the amount of aerosols that's produced. And the main reason is the liquid content comes from the handpiece itself. So if you have a well-isolated tooth and you're drilling with high-speed handpiece and there's no saliva contamination, pretty much 100% of the aerosols that's generated comes from the water that comes from the handpiece, so which is in theory clean water. So there's no risk of contamination by saliva. Contrast that with scaling teeth again as an example, where you have water coming from the dental unit water line, but you also have water coming from the patient's saliva. It's much harder to control that. So the aerosols that are kicked up from that treatment are very different from a well-isolated tooth with a high-speed handpiece. And then the table on the left here, that's from an article from JADA in 2004, and it just recognizes that the greatest source of aerosol contamination is potentially from ultrasonic and air-water syringes. And then if rubber dam is used, a tooth preparation with a high-speed handpiece tends to have minimal contamination potential. So for us, the way we've delineated between AGP and non-AGP is anytime you use a high-speed handpiece or air-water syringe, it automatically falls under AGP. And then if you have a slow-speed handpiece, if you don't use the air-water syringe and a high-speed handpiece, then it's a non-AGP. And for now, the ultrasonic instruments are prohibited until further notice. So that's kind of how we differentiated the two. I recognize that some provinces have different stances. Some recognize that low-speed handpieces are an AGP, and some don't even mention it. So it's kind of a mixed bag of what's out there, but this is our stance. And then very importantly, the table 3 there at the bottom. So those are the aerosol protective measures that we identified. So the most important is probably the rubber dam isolation. So as I mentioned, if you isolate the tooth, there's a very little potential for saliva to seep up through the rubber dam and contaminate the aerosols. Pre-procedural mouth rinse. So this pretty much every dental authority is stating that this should be done. There's conflicting or little evidence on its actual efficacy clinically. But it kind of makes sense because SARS-CoV-2, the virus responsible for COVID-19, is susceptible to hydrogen peroxide. Evidence suggests that it's not susceptible to chlorhexidine, so that's kind of why we made the switch to hydrogen peroxide. And I guess there's no harm there because hydrogen peroxide is also effective against most oral pathogens also. So, and the last point is the effective four-handed dentistry. So, as much as possible, work as teams with the dentist and dental assistant, because effective use of the high volume evacuator has been shown to reduce the amount of aerosols produced by up to 95%, depending on the study you look at. But as much as possible, and you'll see this in the testing results that I'll show at the end, use VHV. And finally, section 3 of the directive talks about the patient care sequence. So it kind of goes through the sequence from triage to the risk assessment, what you do when you receive the patient at the clinic, treatment procedures, and then what you do after to disinfect the operatory. I won't go into detail about each one of those because I'll talk about the annexes instead, and they're kind of incorporated in there. But I'll just point out to really read through the patient reception protocols because there's a lot of really good points out there. I realize that a lot of clinics probably have already implemented a lot of these points, but it might be good to go run through and just make sure you've checked off all the boxes. Okay, moving on to the annexes. So starting with Annex A, there's a lot to unpack here. It's a busy slide, but a lot of good information. So I'll go box by box. So starting at the top, so triage of the patient with the dental care categories. So you're already familiar with categories A and B, emergency and urgent care. This has been our posture from the very start back in March. The RCDC clinics never really shut down like some clinics did on the civilian sector. We were always able to treat those two categories with an emphasis on pharmacotherapy when appropriate. What we've introduced here is the categories C and D. So essential dental care is it's treatment that's required to restore lost function, reduce the likelihood of permanent or long-term adverse effects, or treatment that's required for CAF operational needs. So this is, patients not necessarily in pain, so they don't fall under category B, but they need something done. For example, they've had a root canal done, but they only had a temporary put on top, and that temporary has fallen out. The root canal treatment is at risk of reinfection, so you should treat that patient, otherwise you'll have to redo the endo. And things like things for CAF operation needs, so treatment of deploying members. So if they're deploying and they need some treatment done, then that falls under that essential dental care category. And just to point out that screenings for CAF operations and out-camp postings will always continue. So this falls under this category, but if this category as a whole is prohibited, you can still do the screenings, but it might just consist of administrative review of the patient's dental records. And I understand a lot of people have been doing that for the last several months. So you just go through the dental records to make sure that the patient is fit for their operation or posting. And category D is routine dental care. So that's everything else that can probably wait longer, so like routine phase 1s, dental hygiene therapy, and elective dental treatment. So the box here in the middle, very important. So as the CDO mentioned at the beginning, some categories may be prohibited in the long term. So for example, if a province in particular experiences an upsurge in its COVID-19 outbreak, we may want to reduce to categories A and B again, just in that province, or those detachments that are in that province. And then if the situation improves again, we can expand to ABC or ABCD. So we can kind of move back and forth And we can also do this easily on a national level if there's you know, a second wave that everyone is talking about on the news. We can, you know, nationwide, everyone goes back to A and B only. And I'll just point out, so I saw the CO's task order that came out this week. So these are different from the dental care priorities that the CO has implemented in his task order. So they should be kind of used in conjunction. So the patient should be triaged in accordance to this, but other factors may influence how many patients you can treat. For example, PPE levels may affect how many patients you can treat. So patient triage for the COVID screening questions. So this hasn't really changed all that much. We changed the wording a little bit, but essentially it's been consistent throughout the directives. Question number 1 is also the question you should ask yourself every day before you go to work, before you go into a clinic where there's other people. If you have symptoms, as the CO's task order states, stay home and seek medical advice if needed. Some of these questions, depending on how the patient answers, you may want to refer the patient to medical. So questions 1, 2, or 3. And so I've already talked about the AGP versus non-AGP. And then this table here is where you kind of put it all together and determine how you're going to treat the patient, or if you're going to delay with pharmacotherapy. Annex B, again, so we present this table again, and then this is where you kind of go low risk, high risk, or no treatment. If it's no treatment, you can address remotely with pharmacotherapy. You'll notice that these red X's are for patients that answer yes to some of those screening questions. So you can delay the need for treatment with pharmacotherapy for as long as they, you know, if they improve, if their COVID-19 situation improves, then they fall into a no, and then you can treat them. I won't go through each of those scenarios because it's going to take a while, but it's pretty prescriptive. There's a lot of footnotes that relate to information down at the bottom. 3 to 7 redirect you to different annexes for more information. One important factor here is footnote number 8 here. So if you're treating a high-risk patient in an open operatory, you need a rubber dam. So you can't do like a surgical extraction in an open operatory, for example, if you're using a handpiece. Annex C, so no change here except for the hand hygiene that must extend to the forearms. So you're all familiar with these diagrams by now. And not to diminish the importance of hand hygiene, it's extremely important, but this should be posted wherever you have a sink in your clinic or a hand hygiene station. Now, Annex D, so this is again pretty prescriptive. So it's a visual representation of what PPE you need based on the risk of treatment. So it talks about the high risk and the low risk, and then down at the bottom you have the donning protocols for each situation. Yeah, so we've downgraded from version 2 of the directive on certain aspects. For example, the medical gowns has been, I think we had a level 3 before for high risk and level 1 and 2 for low risk. Now it's a medical gown, and if you look at the directive, medical gown is actually an isolation gown or a surgical gown, as long as it has a level 1 or 2. And then over on the low risk side, it's an isolation gown, any level or unclassified. So some isolation gowns, like the thin, flimsy yellow isolation gowns, tend to be unclassified. They don't have a level associated with them. They just say isolation gown, so that's okay for low risk. And the reason we have level 1 or 2 here is that the providers can decide based on the situation. So if they expect more fluid exposure, then they can, you know, ramp it up to a level 2. And if they don't expect much fluid exposure during the procedure, then a level 1 should be okay. Annex E is the removal protocol. So this protocol is extremely important. The risk of inoculating yourself at any point in the procedure is during removal. If you do it carelessly or quickly, or if you don't, follow the steps with hand hygiene and stuff. So it's incredibly important to follow the steps of this protocol. The protocol itself hasn't changed from version 2. It's just a different way of presenting it with, again, with illustrations. And this is a single pager that can be printed and put it at your PPE doffing station. Annex F is just a sign that you can post at the entrance to your operatory when you're doing an AGP. Annex G, this is what you put at the entrance to your operatory on the door after you've completed the AGP. So pretty simple. You note the time when it was completed, you add the amount of time required, and then it's safe to enter or to re-enter the room at such and such time. And that's just to avoid confusion. If there's a lot of staff going back and forth, that's black on white, you know exactly what you're getting into. Footnote 1 here, very important. So this time of AGP completed is not the time at the end of the procedure when you exit the room, not necessarily. So it's the time when you put down that aerosol generating instrument. So as soon as you put down your high-speed handpiece, if you don't reuse it again throughout the procedure, that's when the clock starts. And footnote 2 here, so this is going to be, if you don't have AFUs, it's going to be 3 hours unless you know the air changes per hour in that room. So it has to be measured by HVAC specialists. And if it's known, then it's going to be likely much less than the 3-hour wait. So that can help you out to see more patients throughout the day. Annex H is the optimal positioning of the AFUs. So very important guide. Again, it can be posted on the wall so that everybody knows where to put what. So the chair side AFU here goes on the dentist side. I've had a lot of questions, why isn't it on the other side? It would make more sense because this kind of instrument arm gets in the way. It actually, that was my first thought too, but it actually was more in the way here with the arm for the suction and air water syringe. And also for the overhead light, I kind of got in the way of that. And it's actually not too much in the way here because the tray for the handpieces kind of goes over the AFU, and it seems to work pretty well. And then very important to put the ambient AFU at the patient's feet, and I'll talk about that in a few slides. And then the last two annexes are a bit more text. So this one is a user guide for those clinics that have the AFUs. It goes into details about what they do, what they don't do, how to assemble them, set them up, how to position them, how to operate them, and stuff like that. And also Annex J is specific to operational environments. So the mobile dental clinics, there's a few sections of the directive that need to be altered for treatment in the MDCs, and they're identified here. Okay, so I'm going to talk into more technical details about the air filtration units. So I'm not an engineer, I'm not a specialist. I just, been researching this for a few months now. So I'll do my best to explain the technical details, and if you have any questions, I'll do my best to answer them. So these are our two AFUs that we've acquired. Chairside AFU is this one here with the funnel, and the ambient AFU is this one here. They're both about the size of a household dehumidifier, maybe a little bit bigger, but that's their size. They both have a medical grade HEPA filter, and the standard for HEPA is 99.97% efficiency at capturing particles that are 0.3 microns in size. And this is the airflow within and around the AFUs. So you can see that they're opposite. So the chairside AFU is top to bottom. So the air enters the unit in the tube, is filtered through the machine, and exits out the bottom of the machine. And then the ambient AFU is the exact opposite. So it enters at the bottom and is filtered up through the top. And so both of them in the clinic, this is how they're going to flow. So this one, the chairside AFU, is obviously meant to capture aerosols at the source, so right at the operating field. And then the ambient AFU needs to be at the patient's feet. And that's very important because if we had it anywhere else in the room, it would just disrupt the airflow within the room. So if you had it behind the providers, for example, I guess the air around here wouldn't know exactly which way to go. So it would be kind of pulled both ways, and it would reduce the efficiency of the chairside AFU here. So very important to have it at the patient's feet. The other very important factor is to have the vents of the chairside or of the ambient AFU. So the vents up at the top of the machine, these are adjustable and they should be pointed straight up at the ceiling. We found that if there was airflow back towards the providers, it kind of disrupted the airflow around here and it reduced the efficiency of the chairside AFU. Now positioning, we have these positioning guides in the annexes. Very important to follow these parameters. The reason why you might think, oh, I'll just move it a little bit further away, 1 or 2 centimeters further away, but it will greatly reduce the efficiency of the machine. So that's because it follows the inverse square law. So if you distance yourself twice the distance from the source, it's not a 2-fold decrease, but a 4-fold decrease. And 3 times the distance is actually a 9-fold decrease in the efficiency of the machine. So try to follow these parameters, as close as possible to the chin, within 20 centimeters of the patient's nose from the top. So from this point, to the patient's nose, about 20 centimeters. You might not need a ruler in the clinic. What I found during testing is that I used the mirror, the mouth mirror. It was like 17 centimeters, so I just added a few centimeters on at the end of the mirror just to make sure that I was following the parameters. And viewed from the side, so this should be almost vertical. So we did a lot of testing with the AFUs. It was done by myself along with DDS3 and DDS4 and expertise from DFHP and CREDI. So Directorate of Forest Health Protection is one of the directorates in health services, and they have some industrial hygienists that work for them that helped us do the testing. And later on, we did some testing with CREDI, the Quality Engineering Test Establishment. That's an entity that belongs to ADM MAP, and they helped us validate the test results that we did with CREDI. So we did some testings just to get familiarized with the equipment, both the AFUs themselves and the air sampling equipment at the Caroline Clinic. Then we moved to Montfort for further testing with DFHP. We also tested them in the MDCs along with ADM MAT with their the big filter that the CDO mentioned earlier. And then later on, a month later, we redid the tests with CREDI. So CREDI is kind of our external validation entity that just to make sure that we're on the right track. We weren't too focused on the details. They assessed our methodology and our results, and they critiqued it. And then we repeated all the tests with them with even more instrumentation, more rigorous methodology, so that we can be really confident in our results. So we did a lot of tests with the AFUs. The first step was to determine the optional cone design. So the company provided us with many different cones. So you can see 3 of them here. There's a small circle, a small rectangle, and the big one that we decided to use in the end. And we found that this configuration was the best. So we call this the inverted cone. We also tried it like this, but found that it was less efficient. And we also, so we used this machine here. It's a capture velocity meter. Basically, it measures the airflow at a point in space. So we kind of move the funnel back and forth to determine the best place to put it. And we also used smoke tubes, these things here, and I have a video on the next slide just to visualize. I hope you can see the video, but this just shows the smoke getting sucked up into the AFU. We also moved the smoke tube around the head just to see the range of capture of the AFU.
Hey, Maxwell, we're just sitting here. I got a question from Richard Kratz, and I'm unsure if you had mentioned it. He asks, what is the ACH with both the ambient and chairside AFU that the RCDs purchased based on a theoretical chart? Can't remember if you stated it earlier.
Yeah, so that's a complex question. Thanks, Rich. So the ACH is basically for the room itself without the AFUs. So it's basically using the building's HVAC system, and that's what we're trying to measure. So the AFUs obviously reduce, or they increase the ACH by a lot, and they reduce the amount of time required. It's very difficult to measure and to calculate both systems together, because there's so many factors, including the size of the room and how many people are in the room and how much movement there is. But in a nutshell, it's having the AFUs greatly reduces the amount of time required. So the testing that we did with Queedy, so we measured the amount of PM10. So PM10 is a technical term, which is the particulate matter that's in the air, suspended in the air, that is 10 microns in size or smaller. You might hear PM2.5 or PM1, so it's the same thing. It's just 1 micron or 2.5 microns. But we measured PM10s, which, as you recall from the previous slides, should capture all of our aerosols, which are 5 microns in size or smaller. So we measured these PM10s with laser photometers, which are these machines here that you can see on the dental chair. So the blue machines there, we had 6 of them altogether scattered throughout the room. And we also had 2 photometers that were worn by us, the providers. So this circle here and this circle here. So this is a tube that captures the air around our breathing zones, just to make sure that anything that would be close enough to be breathed in would be captured by this machine. So it basically, these work, all the photometers work by sucking in air, and it's analyzed with laser photometry inside the machine. So again, another video here. So this is one of those photometers. This one doesn't have the tube extension. It just measures at that point right there. So that's the sensor. And then this is the photometer that's worn by us. So you can see the tube going into the breathing zone. And you can see kind of our setup here. So we had a bunch of these sensors scattered throughout the room at set locations. And so these captured the air at that point, kind of sucks it into the machine and analyzes it here. And these photometers, we had 8 in total. They captured data every second. So 8 data points for every second that we conducted those procedures. So you can imagine there was a lot of data at the end. And we repeated the tests several times. So the test that we did, so with Queedy, we measured aerosol generating procedures, which was defined for us as a 5-minute continuous drilling of natural teeth. So we had some extracted teeth, thanks Major Mark for those. We used a high-speed handpiece that was air-driven. And so basically we just drilled away at the teeth. So it's not really representative of real life, because you wouldn't normally drill for 5 minutes continuously, but the idea was to create as much aerosols as possible to get some consistent readings throughout the tests, because we repeated the tests multiple times. And then background PM10s concentrations was measured 10 minutes at the start of each day and then 5 minutes before each condition. And each of the conditions was repeated 3 or 4 times. So these are the 4 conditions we tested. So they were categorized by group. So group 1 was everything off. So the HV, high volume suction, and the AFUs were off. Then group 2 was only with the AFUs. Group 3 was with both on. And group 4 was only the HV, so no AFUs. And this graph here is the summary of all of the results. So it's a really good slide. It presents the data pretty clearly. You'll note that the scale here is logarithmic, so it's not linear. So this is actually close to 200, whereas this is 5. So it's not it's not 15, it's 200. But you can see that without anything, we created a lot of aerosols, and with both the high volume suction and the AFUs on, it was basically stayed at background level throughout the entire procedure. So that's really encouraging for us. It shows that the AFUs, reduce the amount of aerosols present inside the room and present in our breathing zones. So I have pretty good confidence in those results here. You can also see that with the AFUs only, without using the high volume suction, it's not as good, but I mean, no one would ever do this. You always want to have the high volume suction on, but it's still pretty efficient compared to not having the AFUs. And then lastly, group 4 was the high volume suction only. Again, not as good as having both on, but it's much less than having the nothing on. And so last slide here. So this is the graphs in more, or the presentation of the data in more detail. Believe it or not, this is the simplified version of the graphs. But just to go through, these are the 4 groups again. So group 1, 2, 3, and 4. So group 1 and 2 were without the high volume suction. And you can see that each condition was repeated. For those 2, it was repeated 4 times. So we repeated the experiment 4 times here. And for groups 3 and 4, we repeated the experiment 3 times. And you can see spikes when we do the procedure. So this is a measurement of the PM10s for all of the sensors combined together. We can see spikes during the 5-minute procedure in this range here. And then as soon as we stop the procedure, the particulate matter in the air started to decrease. So there's a difference here between the yellow boxes and the green boxes. So the yellow is what we called natural clearing. So we didn't use the AFUs at all. And the green boxes are when we use the AFUs to clear the room after the procedure. So you can't really tell on here because of the scale, but if you just look at this one here down at the bottom, so this one here, so you can see that the slope changes right when we start using the AFU. So the room was clearing slowly, and then as soon as we turned on the AFU, the slope changes dramatically, and that just shows you that the AFUs are much more effective at clearing the room after a procedure, as opposed to just letting it clear by itself. Another thing I want to mention too is that the scales are different. So here it goes from 0 to 25, and here it's 0 to 0.5. So even though you might think that these are big spikes, they're actually very tiny in comparison to what's happening here. So when we have both the high volume suction and the AFUs used, the highest ever recordings were around 0.4, 0.5. So it's pretty small in comparison to upwards of 20, 25. And yeah, so that's all I wanted to mention here. And I think that's the end of the slideshow. Yeah. So I
Hey,
will
Max,
open up the floor.
that was an incredibly great, well-timed presentation. We've got a couple questions here. You may have mentioned, and I apologize. One of the questions was, is it 20 minutes after aerosol generating procedure before we can reuse the room? And I just want to reconfirm this. Amir made it a statement here, and I just want to have it in the recording so when we replay it, people have it. How much time is required after the procedure and then before the room can be reused after an aerosol generating procedure?
So that, I guess that depends if you have the AFUs. So if you do have the AFUs, then you're supposed to wait 10 minutes after you have used an aerosol generating instrument. So if you do an endo or a pulpectomy, and you use the high-speed handpiece way at the start of the procedure, you don't need to wait that 10 minutes. It's passed already. So you can leave the room right away, but the room remains closed for an additional 20 minutes after that.
Okay, that's a great explanation. So there was a couple statements here about the chairside AFU's hose is very loose, and then Lieutenant Colonel Langevin had mentioned that you had increased the length of the hose from 4 feet to 4 feet to give more room for positioning. But you still can cut the hose if you don't need that positioning. And then there's a statement about a hose clamp from Home Depot just to tighten it. Any words on that?
Yeah, so I did experience that myself when I was doing the testing. So if you look here at the neck of this AFU, so this part here is fairly rigid, but this part can be removed. So it's basically like a rubber wrapping around the neck of the machine that can allow the bend to occur a little bit lower. These are also all interconnected and they just snap into place. So what can be done is if you find that it's too long, because we did add that extra foot just to give more flexibility in the placement. If you find that you only need 3.5 feet versus the 4, these can be disconnected and removed and reconnected. So they're pretty flexible. I've found that after repeated use, the neck got a little looser and it tended to like drift down away. So yeah, just to make sure that we do have maintain efficiency of the filtration, like people could start using clamps and stuff like that, just as long as they're properly disinfected after the procedure. That I would encourage that. Yeah.
Well, that's a great point. I want to add here, I made a mistake as usual. Don't cut it, but disarticulate it if you want to remove length. I think that's a better way of stating it. So Another question is, so for example, in our clinic, if we don't have level 2 to 3 masks for low risk procedures, can we use a level 1 mask?
So the directive states level 2 and 3. The difference between the two essentially is fluid resistance. But level 2 and 3 tends to be, the difference is minimal. When you drop down to a level 1, it's a much bigger change in the level of fluid resistance. So I would discourage using level 1 for treatment. I would prioritize those for continuous masking, both level 1 and there are some masks that are unclassified, so that they don't have an ASTM level. So those can be prioritized for continuous masking, patient reception, that type of stuff. But for treatment, I would encourage level 2 and 3.
You know, that's a great, and that kind of falls into this next question by Angie Heyman. She says, she had mentioned that please mention removing rubber dam can produce saliva flying up. So definitely your discussion about fluid resistance is applicable there. But also the part of the rest of the question has to ask, so if saliva would be flying off when you remove that rubber dam, would that be considered as a high risk procedure then?
Well, it's hard to be prescriptive for all the different scenarios, everything that can happen in the clinic. You know, patients cough all the time. If you're taking an X-ray, they might be you know, more prone to gagging, that type of thing. So it's really hard to capture all of the scenarios. What I would say is just use common sense. You know, whenever we remove rubber dam, we always, you know, use a saliva ejector under the dam just to make sure that there's as little saliva as possible underneath, and the patient is less likely to cough at that point, and fluids are less likely to go everywhere, so to speak. But no, it doesn't necessarily classify the procedure as a high risk. What I would say is just use common sense and be careful.
You know, and I'll add to that. I mean, we have a great chain of command that we can use. And, you know, if you have any of these questions, you can ask your deck commander and your clinic coordinator. Those are, you know, they're experienced people, and they've been in a lot of teleconferences regarding a lot of the safety for providers and patients. Okay, so another question we're going to have, another statement here actually was from Karen, Major Karen Holden. She says, what about combining a level 1 mask with a face shield? Would this work to mitigate the issues with a level 1 mask? I might have muted you, Max.
Yeah, I think I'm unmuted now.
Okay, good.
Yeah, that's a good point. From my understanding, face shields are in short supply, so they should probably be prioritized for a high risk treatment. But yes, they do protect the face as well as other PPE from contamination during treatment. So the face shield is always worn in a high risk treatment to protect the N95, to protect the eye protection that's worn underneath from fluid spatter, and that will help reduce the risk of self-inoculation after the procedure when you're removing the PPE. That's something that we can look into, though, for sure. If there's a shortage of level 2 and 3 mask, and you know, ample supply of face shields, that's something that we can look into for sure.
That's right.
So actually, Chief and I were back on as well for the Q&A. There's other questions, and Max were there. Hopefully you can hear us.
Yeah, absolutely, sir. Another question we have here, just about regarding, so a hygienist, Darcy Cormier asks, so under the non-aerosol jetting procedures, if a hygienist is hand scaling and avoiding the use of Cavitron, are we allowed to use the air water tip? It says prohibited.
Well, anytime the air water syringe is used, it becomes a high risk procedure. So if you use it in spray mode, you know, with both buttons on, with the air and the water at the same time, that vaporizes a lot of water, and if it bounces off the patient's saliva, then that's obviously a greater risk of exposure to the aerosols. If you need the patient to rinse, I would recommend them using a water cup instead of using the air water syringe.
And just to finish off another question, I didn't really, as my apologies, from Marilyn Guéron. She said, you know, she's asking, I just feel it's like a waste to use an N95 for a phase 1 if we don't have class 2 or class 3 masks.
Go ahead, Max, but we don't use N95 for phase 1.
Yeah, no. So yeah, so if there's no, she's asking if there's no level 2 or 3 mask, if you only have level 1s.
Yeah, if they were doing an annual exam, yeah. You know, if out of class 2 or class 3, do they go up to an N95?
Okay. From my understanding, that's not the situation. I thought that the PPE supply situation with regards to mask was not really an issue. CDO, do you have any points there?
Yeah, the issue that we have is the N95. So we have to be very cognizant that when we use the N95, it's for the higher risk procedures. So to do a phase 1, and I would find that a bit odd that in our clinics we would not have an ASTM level 2 or 3 mask, but access to N95. So that's something that will need to be discussed with your detachment commander to see what the level of supply you have. Because if we reach a point where for the low risk procedure, we need to engage in using N95, that's really problematic system-wide. So we'll need to reshuffle, or the unit will need to reshuffle their supply accordingly.
Yeah, absolutely. And that's, you know, Karen's writing me privately, you know, the chain of command should be contacted and we can share masks between different debts if we're running out. So it's keeping track with your detachment headquarters staff just to make sure that your supplies are good to go. Any other points there, sir? Or just we're kind of in a pause here for questions and statements.
So if there is no further questions, Max, any other points you'd like to discuss?
No, sir.
No, so I can give some concluding remarks.
Absolutely, sir.
Excellent. So Chief Gauthier and I really want to thank you for your professionalism, your patience as we're navigating through that crisis. We've been entrusted to take care of the most important patient of this nation. You heard that, or you heard me say that many times. Our women and men in uniform, and they certainly deserve the best of what we can do. So let's be our best. Let's strive for excellence. Please take care of yourself and your family. Stay healthy, stay safe, steadfast, and strong. Thank you, folks.
Take care.
All right, thank you very much, everybody. And we placed the replay online. And if you have any other questions, go ahead and either email me direct, or you can email Max Major Fournier, and we can. And also, don't forget you have your chain of command. So keep your dead commander, ask them questions, because I know there's a lot of questions out there. And when you get back to work, feel free to contact your dead commander and your clinic coordinator. All right, Max, thank you so much. You did a great job. I really appreciate it.
Thank you.
Great job, Max.
Yeah, have a good one, everybody.
Thank you.